This conference will now be recorded.
So welcome everybody. High risk, recurrent and advanced prostate cancer virtual group. And we have at least one new gentleman who is new to you. He's not new to those of us who are on the Speaking Freely call last Thursday night. But we'll give him plenty of time to tell us a little bit about his situation. And he's a support group veteran as well. Somebody just called in on the telephone. Who might that be?
It's Jim from Colorado.
Hello, Jim from Colorado. Another gentleman who was on the Speaking Freely call.
You're gonna have to name him, Rick. I'm having a problem. My your GoToMeeting's not working right.
Okay, that's fine. That's okay. Okay. So let me just. All right. Now, so we have two new gentlemen on the call, which is great. So I'm going to read out those who I see on the call. You'll let me know if we miss anybody, and then we'll dive straight into the two new gents. We've got Jake, Carl Foreman, Bruce Shrimp, Joel Blanchette, Paul Frieda, Dennis Correa, Jerry Pelfrey, Len Sierra, Ken Anderson, Larry Fish, Peter Kafka, and Jim from Colorado. Did I miss anybody? Okay. So for the benefit of the two new gents, this call is a little bit different to the call that Rich Jackson moderated a couple of last Thursday, in that on this call, we welcome you getting into your technical issues. We don't steer away from them. We are here to listen to you tell us about your treatment history, and where you are right now, and if you have any challenges. And then we have a really good group of guys on here with a lot of knowledge between us all. And the idea is, it's just to share, of course, if you just want to tell us where you're at, but also if you've got any particular issues, to try and brainstorm and develop a strategy to help you navigate your treatment with your doc, to come up with better questions, ideas, thoughts that maybe you haven't looked at yet. So the two new gentlemen are Bruce Shrimp and Jim from Colorado. What we usually do is go to the new guys, and we let you talk to us for about 10 minutes or so about your situation, and then we'll spend another 10 minutes or so just batting around the issues that you raise. And we'll do that. We'll do it first with Bruce, and then follow that up with Jim. I'm starting with Bruce because I know how comfortable he is telling everybody, because he did such a great job on Thursday. So Bruce, you got the microphone.
Well, thank you very much. I was diagnosed in November of 2017 after completing proton beam radiation therapy for a non-cancerous tumor on my right vocal cord. The doctor up there who was there, I saw a neurologist, he said, we better check for more of those non-cancerous tumors. So he did, and they ran me through a CAT scan and a PET scan and discovered that I also had prostate cancer. I was diagnosed with a Gleason 9 My PSA was 12.3. The last time I had a PSA test, I was with my doctor. I live in Milwaukee, and the PSA was 9, having gone from 6 about a year earlier. So I asked the doc, I said, shouldn't I be aren't you supposed to do a DRA, and shouldn't I be getting a biopsy? And he said, well, we'll do that in November. Well, this was November of 2017, and I was at the Mayo Clinic, and they said, well, Mr. Shrimp, you've got prostate cancer, and you got a bad case of it. By that time, I was a PSA 12.3. I was a T2C tumor. There was extra gland extension, and there were some suspicious nodes, and my right vesicule, seminal vesicule, was involved. So they allowed me to go home for the Christmas holidays, and then they started me on Lupron with a 4-month shot, and I returned to the Mayo Clinic to get ready for the proton beam radiation to the prostate. By that point, my PSA was 1.7, and they were concerned about a couple of lymph nodes, but the PSA had dropped and the lymph nodes did not change appearance. So my doc looked at me and he said, I don't think those are cancerous, but we're going to treat them anyway. So that's what happened. On January 28th of 2018, I started 26 sessions of proton beam therapy, and that was pretty much it. I never had Casedex. I never had anything else. I completed the proton beam therapy, and my doc said that he was going to keep me on Lupron for 18 months. So I had my last shot at the Mayo Clinic on June 27th of this year. And no, I'm sorry, on April 1st. And April 1st shot was a 3 months, and that ran out the way they calculate this, I think, on June 27th. So on June 27th, I had a PSA and a testosterone, and my PSA was now 0.0. And my testosterone was less than 2. And now I'm in a holding pattern and waiting and seeing what's going to happen.
Okay. Thanks, Bruce. A couple of really interesting things, because I've heard this once before, and I think from Mayo too, that when they gave you the ADT to begin with, before you started your proton beam, are you saying they did not give you any Casedex before that?
No. Well, they gave me something else with my first shot, and it was so that there wouldn't be a bloom of the testosterone. And I honestly don't remember what that was.
They gave you, what they did is the first shot they gave you was probably Firmagon, and then they switched you to Lupron. Okay.
All right, that could be.
Yeah, because the Firmagon doesn't cause a spike in the testosterone, and now you're waiting now to see how you do. One thing I want to mention to you, and I just realized I think I was supposed to send this to John Appler last week, and I don't think I did, but I'll do it afterwards. John Appler and Bruce. The way that PSA comes back after you stop ADT can be pretty strange. And there is an explanation, and I have a little hand-drawn graph. It was explained to me one time by a radiation oncologist from MD Anderson called Stephen Frank. But what I want to say to you is don't be alarmed if your PSA climbs before it falls. That happened to me, and my PSA rose for almost a year. And it went all the way up to, I think, 0.97. And my doc kept saying to me, don't worry, it's going to come down, it's going to come down, don't worry. And after 4 or 5 months, I thought to myself, well, if the treatment didn't work, it didn't work. I just got to, go on to the next phase. And Matt kept saying to me, no, don't worry, it's going to come down. And sure enough, he was right. And around the year mark, it turned and then went down to less than 0.1. And the problem that I see from this is that if you don't get warned, and most of the times these radoncs don't warn you, then you get very upset and anxious for no good reason. So, and I will also say that it took from February to August, and I was quite young at the time. I was 58, I think, or 59. It took from February to the August for me to even register testosterone and to start registering PSA. So, be a little patient. Your last shot wore off in June of this year, so it may. No, well
I misspoke. It was April of this year, and it's wearing off starting in June.
Yeah, that's what I said. Your last shot wore off in June of this year.
Right.
And so it may well be that you do not see anything until towards the end of the year. And then it's going to climb. It could climb for a while. And I'll send you this little graph rather than try and explain it to you and bore the pants off everybody. I'll send you this little graph, and then you can call me or email me, or we can talk and we're some way or other, and I can explain it to you. But I think you'll get what it is. I just realized I was supposed to send it to another one of our guys last week and forgot. So both of you will get it this week. So tell us.
Well, I greatly appreciate that.
Okay, tell us if you have any questions, and then I'll throw it out to the guys to talk to you.
Well, with this last shot, I mean, I'm a lawyer. I've had no memory problems. I've had no concentration problems. I do have mood swings. I have had depression. I go into depressive episodes a little bit less now, but I exercise regularly, and I'm on sort of a Mediterranean diet. I say sort of because I also have a couple of cocktails at night. I'm a lawyer after all. And I have noticed that I have balance problems and dizziness problems that have shown up with this last shot. I've not had it before.
Mm-hmm. Well, guys, I have some input on that, but let me throw it out to anybody on the call. Does anybody have any input for Bruce?
I don't think that's unusual. Or was it Jim?
Bruce.
Oh, Bruce. I think the dizziness, lightheadedness, balance issues, that's kind of typical for Lupron. Just a couple of questions, though. And maybe Rick, see if you agree. I was very surprised to hear that after being on just Lupron alone, his T level was just 2. I've never heard of that before. Not that it matters one way or another. I guess it's a good thing, but usually on Lupron alone, the T levels are in the teens, if not higher. The other thing is, I believe you said they diagnosed you as T2C, even though
Yes.
you had seminal vesicle involvement and extracapsular extension, which
Yes.
I think would be considered T3B. And again, this is just a technical issue. It doesn't affect the success of your treatment in any way. It sounds like you responded very well. When they did a biopsy, did they tell you how many cores were positive and how bulky the disease was?
No, that they did not. I've even rechecked the records from Mayo, and there's no indication, because I know a lot of guys know how many cores were positive and what the density was, but I really don't.
Yeah, I mean, you can probably get, I'm certain if you wanted it, you could get a copy of your biopsy report from Mayo. Is there anyone on the call? Unfortunately, Les is not on the call today. I'm wondering if there's anyone else who goes to Mayo. I know Peter's been to Mayo who's had a biopsy there, and can report on what sort of information they give you on the biopsy.
This is Jim in Colorado. I got a complete pathology report that gave me an image on paper of my entire prostate and all of the cores and everything they did and what each core looked like. And they also, and they looked at the edges, and they gave me, I mean, everything I could, it was incredibly valuable going forward, because I could see, where in my prostate was the worst numbers. And they gave me a 5-page pathology report that included a photograph of my prostate broken into the cores.
And where was
I would
this
think
from?
you could get that if you just ask.
And was that from Mayo,
No.
Jim? No.
No, that was from it was from Cleveland Clinic.
From Cleveland Clinic, that's what I thought. Yeah. Well, you see, the thing is, it's always good to get the full reports, the biopsy report, if you had surgery, the surgical report. And Bruce, I would encourage you to ask them, in your case, for the biopsy report, because there's good information in there. And I think what Len alludes to, which is how much cancer you had, right now, you don't need to know, and hopefully you'll never need to know. But if the cancer were to come back, then it might be an issue. And where it was, as Jim says, where it was in the prostate, what part of the prostate it was in, because different parts have different implications.
I appreciate knowing that, and I will certainly ask him for it.
Yeah. Anybody else like to ask any questions to Bruce?
Yeah, this is Jim again. I'm sorry I'm talking so much, but are you taking the Lupron on a 3-month basis or 1-month shot? In terms of the side effects, how frequent, what dose have you decided on for yourself?
All of my shots were 4-month shots, with the exception of the last one, which was a 3-month, to make it come out to 18 months.
Okay. The reason I ask is I was on 3-month Lupron shots with Zytiga. When I stopped doing it, when I went back on, I went to monthly shots.
Jim, let me interrupt, because we'll come to you in a minute. I know that's an issue for you, and I'm on Thursday, and so we'll talk a little bit about your situation and get into it when you introduce yourself, rather than talking about it now, if that's okay.
No, I just wanted to make sure that he should, maybe ask his oncologist.
He's done. He's done, Jim. He's not getting any more Lupron shots.
All right.
His last Lupron shot was in June. It was in April, and so it wore off in June. So it's not an issue. It's not an issue for for Bruce. I know it's an issue for you, and we'll definitely address it momentarily. Yeah, and I do also want to comment on Len's remark that your testosterone is pretty low. I mean, that is real low for just being on Lupron or an LHRH alone. Did you check the level of your testosterone before you started on ADT, Bruce?
I knew I did not separately check it. However, I checked it because I had ED, and I checked it a couple of years ago, and I knew that I had low testosterone. I was in the low 100s.
Okay. Well, that may explain it, because that's where I was going. So it could explain it, and it's also going to be important for you in terms of your testosterone returning, because the likelihood is that it'll return to its base level, hopefully, but if the base level is very low, then you've gotten back to where you were beforehand. So that,
well,
go ahead.
One of the things that I have asked for both my urologist in the Milwaukee area and the oncologist at Mayo is when they do I'm getting quarterly tests, except Mayo, they want semi-annual. So I get quarterly tests down here and semi-annual at the Mayo Clinic. And I've asked for a testosterone and a PSA on all of them, and they've both been cooperative, and they are going to do that.
Oh, good. Okay. Yeah, I mean, I think monitoring it quarterly is just fine. I mean, I monitored mine monthly to begin with, but if you're happy with quarterly, stick with quarterly. So, I mean, I think at least to begin with, the first 3 to 6 months, you're not going to see much beyond quarterly anyway, it seems. Okay, anyone else want to chime in?
Did we get a Gleason score on Bruce?
5
yes,
plus 4.
my Gleason was 5 plus 4 equals 9.
Wow, then you definitely had an incredible response, an incredibly good response. Congratulations on that.
Well, thank you.
Okay, Jim, now you have...
Rick, before you go on.
Yes.
Peter, can you turn your phone down? I had to mute you. We're getting a lot of feedback coming from you. Or mute your phone. I muted you.
Thanks.
Sorry, Rick.
Okay.
Jim, Rick?
Yes.
I'm sorry. Just one other question. Bruce, you said you had proton beam. So did they use the proton beam to hit your prostate, seminal vesicles, and pelvic lymph nodes?
Yes.
That's the first I've ever heard of proton beam being used for that type of wide-angle radiation. I always thought that proton beam was used for much more narrow angle treatment. Would you agree with that, Rick?
No, I think stereo. I mean, look, Peter had and Les both had their abdominal area radiated with proton beam, and I think the proton beam can be used in a diffuse fashion. It's not really like CyberKnife. It's not narrow and intense like CyberKnife. It's just that as I understand it, the penetration of the beam is very different. Has a much different pattern. Isn't that right, Paul Frieda? We have to go to our resident physicist here. Is that right, Paul Frieda, that the proton beam has a different penetration to whatever you call the regular beam?
Yeah, it gives up its energy all at one point, and you can control that with the energy of the beam. So it spares the inner the tissue in between, and that's true of all ions. So proton is just the ion of a hydrogen atom, but we used to use carbon and some other and oxygen sometimes too, but apparently that never made it into commercial use. But an ion gives up all its energy at one spot rather than giving it all through the tissue.
They do use carbon ion radiation in Japan for prostate cancer.
Okay, there you go. Yeah.
Also, I believe in Heidelberg, Germany.
Yeah, I don't understand why America seems to be behind other places. I just don't get it.
We don't have government subsidized medical treatment. Carbon ion beams are incredibly expensive, like I think $100 million.
Is that right? Really? Not exactly sure why.
To see it in the U.S.
Well, for just the beam, all you do is you make a gas. You heat up the element, make a gas, and you strike an arc, and then you put a screen nearby with a voltage that sweeps out the ions, and that's not very. I don't understand why carbon would be that much more difficult.
Well, maybe they'll hire you
for about 20 years. So.
Okay.
Bruce, this is Peter. I have a quick question for Bruce regarding any side effects from the proton therapy. Did you any urinary side effects or any erectile function side effects as a result of the proton beam?
I had ED for years before I was diagnosed with prostate cancer. Actually, after I came back from the clinic, I started with a pelvic floor therapist, and my ED is slowly, very slowly, beginning to resolve itself. Even now, I still have to take sildenafil, and I have to watch dirty movies, in order to get the right reaction. But I've even, I had a dry orgasm, but I even have been able to achieve orgasms. The only side effect, and I'm not joking, the only side effect was about 6 months after I finished at the Mayo Clinic, and that was in March of 2018. I was on a trip, and I had some minor burning irritation when I urinated, and that only lasted a few days. And then, I'm not joking, other than that, I've had no side effects. Except hot flashes, periods of depression, and mood swings. Those are the major side effects.
Right, but that would be the ADT. That wouldn't be the proton beam therapy. Very good.
Right.
Good report.
All right, thank you.
Yeah, and I do want to tell you that this lightheadedness and dizziness, as Len said, is common, and the balance issues also are quite common. I never had good balance, and the ADT made my balance even worse. And I have no idea, what you do to correct that, other than some of the exercises I try to do when I go to the gym. I work on my balance. Sorry, guys.
Right.
So let's move on and let's pick up with Jim. And Jim, maybe you can go through the same exercise. Tell us a little bit about your history and what you've done, and then raise any issues that that you have.
I'd be happy to, because it's hard to talk to most other people about it. But about 22 months ago, my primary care physician insisted I have a blood test. I hadn't had a full blood panel in years. My PSA was 233, and everything else was normal. I felt fine. I was hiking 1400-foot mountains. I was absolutely fine. And then all of a sudden, he tells me, let's redo it. We redid it. It was 233 again. So at least it wasn't going up. And he referred me to a urology clinic. They said, we need to do a biopsy. I did my biopsy, and they said, you're Gleason 9, you're 4+5, all 12 cores are infected. There's ragged edges. We can't do surgery. We don't recommend radiation. But in the CAT scan that they had done, they found a tumor on my rib. And they radiated that rib, and they gave me Firmagon for 3 months. I wasn't happy after, researching the information, and I did a second opinion at Cleveland Clinic. They said, yes, you've got, do the radiation on the rib, and the Firmagon we don't recommend. We recommend that you do Lupron and Zytiga plus prednisone. And they also suggested I go to a teaching hospital as opposed to a urology clinic. So I did all of that. The Firmagon was awful because I don't know whether it was just inexperience on the people that were injecting it into my stomach, but I literally was black and blue all over my midsection for 3 months. I ended up going to University of Colorado Health, recommended by Cleveland Clinic, a urologist there, or urology oncologist there, and they immediately switched me to Lupron plus Zytiga, which was the recommendation from my second opinion. My PSA started to go down. It took about 8 months into it. My PSA was 1.1. My testosterone went from 6 and change to less than 7. The ADT was driving me absolutely crazy. I was ready to commit suicide. So I had read that you could do intermittent. So I told my oncologist, I can't do this anymore. And all of them, Cleveland Clinic, my second opinion, UC Health, and the urology clinic I first went to, all said surgery and radiation are not options for you. ADT was it. And they said, I'll quote, we can't cure you, but we can hopefully allow you to live a little longer. Well, my reaction to the ADT was I didn't want to live a little longer. It was that awful. So I decided to quit last August of 18. And I said, I'm not taking any more of this stuff. Let's just watch it and see what happens. By January, my PSA went from 1.1 to 48. My testosterone went back up to 600. And after about 3 months, the side effects from the ADT were virtually gone. I felt pretty good. And, one of the things we talked about last Thursday, explaining to people, you know, your weight gain, your breast enlargement, your belly bloating, and your lack of energy was something that was, you know, psychologically just life-changing for me, because I'd always been active. I live in the mountains of Colorado and have for a long time, and outdoors meant something. So in January of this year, when my PSA shot up to 48 again after a few months, I went back on Lupron. I did the Lupron for 3 months. Well, I did monthly shots, so the side effects were much better than when I did the 3-month shots. And I ended up, I bottomed out with my PSA at 9. And then we added Zytiga a few months ago, and now I was there Friday. My PSA is 2.6. But my big question is, in January, after they had told me all 3 places I had been to said radiation was not an option. Then in January, I was told by my oncologist at UC Health, Colorado Health, that maybe radiation will work. And I met with the radiation oncologist. And I also met with the surgeon who said, no, you're not a candidate for surgery, but maybe radiation. I went, and the radiation oncologist sounded like a used car salesman, but I looked up, radiation for someone who's Gleason 9 in my situation, and I figured if I'm going to do it, I should look at proton therapy. So I contacted Mayo in Phoenix, and I contacted Anderson in Houston. I contacted the local CyberKnife guy, who basically said no way. And in the meantime, after they did an MRI in January, they found that it was in my lymph system. They found 3 lymph nodes that were positive for cancer. My rib that they radiated did not come back. So I had to make a decision on whether or not to do external beam radiation here in Colorado or go to Houston or Phoenix. Well, I talked to Houston and Phoenix, Mayo and Anderson. Both of them said that it would be 10 weeks, 9 to 10 weeks, plus my travel time. And I again did a second opinion with the same oncologist at Cleveland, and he said I would do external beam. But he didn't explain why. And I'm looking at it now. I'm feeling pretty good except for the side effects. But my question for anybody who's been through something even remotely similar is the radiation, and I'll add one more piece, the oncologist from Cleveland Clinic, my oncologist here in Colorado, and both Mayo and Houston said you're looking at 6 months additional extended life if I do the radiation. And I looked at it and went, 10 weeks plus the side effects, and knowing how involved my prostate is, that they're going to have to get it all. They're going to not only have to do the lymph nodes, they got to get all the prostate. It isn't specific. And I decided to not do the radiation, that I would just stay on ADT and manage it the best I can. And like everybody else who said, I'm dizzy, I can't safely drive, I can't do all the things I love doing. It's a total quality of life thing. But if I do the radiation, according to my oncologist, I'll still have to do Lupron. And he said, probably for the rest of your life.
Well,
so I'm figuring.
Let me jump in. because I want to make sure we have enough time for the guys to talk to you, and then we have to get around everybody. And one thing you didn't tell us, how old are you, Jim?
I was 65 when I was diagnosed. I'm 67 now.
Okay. So I want to turn to somebody who's in their late 50s who has done some radiation after being diagnosed metastatic, and who is trying to preserve their quality of life to the extent that they, if you read it on our blog, just completed a 150-mile hike over 15 days in the mountains, and has been on ADT for 2 or 3 years now. And I want that to be an inspiration for you, but I really want to talk to Ken, because Ken, after he did chemotherapy and Lupron, then decided to do radiation and debulk the primary. And Ken's treatment is managed mostly out of MD Anderson, with support locally in Phoenix. Ken, you want to talk to Jim a little bit about your situation and his situation?
You know, can you hear me?
We can. You're a bit scratchy.
Yeah, sorry about that. If I have to, I can switch to a different mic.
Okay.
You can let me know if I need to.
Okay.
Yeah, Jim, I was diagnosed 3 years ago, and I went straight on Lupron. I hear everything you say in regards to your treatment and how you go mental, or, I mean, it's a tough diagnosis, there's no question. I mean, I think you've reached out to all the right places to try to get information. Well, I can just tell you what I've done, and you can kind of take it for what it is, you know. And I understand you trying to explore, because truly, having no testosterone in your late 50s or early 60s is a word.
Ken, can we get you to switch to that other microphone, please?
Yeah, you can. Well,
Thank you.
you guys can talk, and I'll switch.
Yeah.
While we're waiting for Ken to hook up a new microphone, we're getting some feedback. So anybody who's not speaking, please mute yourself, and then unmute yourself when you're ready to say something, please. Thanks.
All right, I'm back.
Okay.
So let's kind of take it from the top again. You know, I was diagnosed 3 years ago here in Phoenix. Long story short, I was a Gleason 9. I have bone mets and lymph node involvement. I was told that I needed to go on ADT, which is Lupron, and I went straight on it and haven't gone off it since then. The whole thing about, you know, dealing, the hot flashes get better over time. Losing muscle mass and just general fatigue is always an issue, or was for me. The only way I found to deal with it is to exercise my butt off. As far as taking the next step and going on to having your prostate, and again, it's not a curative measure, and I don't think anyone knows whether or not the advantage for having IMRT or radiation to the prostate and having the primary removed. There's only 2 ways to like remove the primary, and one is take it out, and 2 is to radiate it in some fashion, and it's trying to address the cancers at its source. So, I mean, for me, having surgery, I didn't find having surgery in general was a good approach. So I opted to do radiation, and the radiation's done over 2 months, and it's fairly easily tolerated. It's a pain in the butt because it's, you know, 5 days a week for almost 2 months worth. You get Saturdays and Sundays off, and it's about a 15-minute adventure for 2 months, but it's pretty easily done. So, Jim, do you have any questions for me? I don't like talking on my own.
I'm sorry, I muted myself. Yeah, one of the issues that whether I do proton or external beam is proton, I have to go to Phoenix or Houston. External beam I could do in Colorado, but I have an hour and a half drive. And I know you have to do an enema and, there's issues, especially about halfway through. And I have family and friends that I can, I don't want to stay in a hotel by myself. So that was part of my decision. Were you close to where you were getting, and did you do external beam or proton? Because you're in Phoenix, you have your choice.
Well, I actually go to Houston for like consults. I see a doctor there, and he advised me that there wasn't any advantage from doing one over the other, and that people may disagree, but that was his comment. So I opted to do something locally, and I did IMRT, which is, external beam radiation to the prostate gland and to the prostate bed. I think it was like 72 gray or 80 gray or something like that, small doses over a period of time. So.
And did they do your lymph nodes?
They did the ones that were close to the prostate bed. They didn't go outside of the prostate bed, though.
Okay.
And I did notice a decrease in PSA upon radiation. So what they did was effective. It didn't take away the need to have Lupron. And like I said, the side effects after 7 months or 8 months on Lupron, the side effects get easier to manage. I must admit, though, I also haven't done Zytiga or enzalutamide yet. I'm going to start that probably in the next couple of months. Right now, I'm going on to Provenge, starting that on Friday, which is an immunotherapy.
Yeah.
So let me just point out, Jim, that you don't do an enema every day. You don't have to do an enema before every radiation sitting. So yes, you may need an enema if they're going to put in fiduciaries to guide the radiation, or if they're going to do some sort of a procedure. But otherwise, you don't. It's not a daily enema. Notwithstanding, an hour and a half each way is sufficient. I mean, Ken, you had a bit of a hike of a drive because you had to go from North Phoenix to South Phoenix every day. Yeah. I mean, you probably had.
Yeah, it was an hour drive.
I did. Yeah.
Yeah, it was an hour drive each morning down. Made an adventure out of it. I went first thing in the morning each morning at 7:20 a.m. So I left my house at dark. It was in the winter time, so it was dark when I left. So you can manage it, though. It's not, I mean, I don't know if where you're located in Colorado, there's a radio oncologist available.
No, I'm in the sticks. I'm in the mountains.
Right.
And I'm not in like Vail or Aspen. I'm in the, the stick part of the mountains.
Right.
And so you got to worry about weather every day, and not in the summer. That's why this decision for me is, timely, because when it gets to, December, January, February, March, I'm, I have no choice, but I'll have to, get a hotel and spend 9 months in a hotel.
Right.
Yeah.
I got to tell you, I wouldn't allow anyone's comment in regards to the extended overall life, like if you get 6 extra months. I mean, how the hell do they know how many extra months you get if you do IMRT to your prostate gland? I mean, the fact is that you get a benefit, and the benefit is worthy of the effort. So whether it's month or 2 years, I mean, I would say, and I know Lupron is not fun. I mean, I emotionally, I was on an emotional roller coaster, and still, I'm better today than I was in the beginning. But you do get better over time. And as far as, growing breast, with this gynecomastia, you can take a drug called tamoxifen that helps with that.
Yeah, I just got that yesterday.
Gotcha. Well, you can always contact me direct if you want to chat about any other things, stuff that I've gone through. I have been going through it. When did you start your first treatments, or actually you've been on and off?
Close to 2 years ago, but then I stopped for 5 months.
Yeah. Well, Rick can put us in touch, and we can chat anytime you'd like.
That'd be great. Thank you.
Yeah, and we've got some other guys on this call who might want to talk. We've got some guys that have been managing disease and were diagnosed metastatic as you were, and have been managing it for quite a bit longer than you, and who I think can encourage you. Is who else on the call would like to give some words of encouragement to Jim?
Jim, this is Peter. I was faced with having to do I didn't have to, but I chose to do radiation far from home. And people were generous and gave me places to stay. And I parked myself in San Francisco for 3 months several years ago to do IMRT. And I have no regrets about it. I treated it like a vacation. I went to museums and plays and movies and had a great time, and just made it work. I live in Hawaii and chose not to get radiation here and chose to do it on the mainland. Since that time, I've also had proton beam radiation for metastatic lymph nodes, and I had that with Carl Rossi at California Proton Center, and he's by far the most experienced proton radiation guy around. He's done over 10,000 treatments for men with prostate cancer. And he might, if you're willing to travel. Huh?
Is he in the Bay Area?
No, he's in San Diego, California Proton Center in San Diego, Dr. Carl Rossi. And he's got quite a bit of experience. He might be good to get another opinion from him.
Well, I found that other opinions never hurt.
Right. Yeah, we also have a friend who lives in Breckenridge who did his primary treatment with Dr. Rossi in San Diego, and he was a Gleason 10, and he's still doing fine.
Who else has something that they'd like to say? Who else was diagnosed metastatic on this call and has been managing the disease with and without Lupron for a period of years?
I have. This is Jake, Jim.
Yep.
I was diagnosed metastatic in 2012. It'll be exactly 7 years this month, or it was exactly 7 years this month. And I've been managing. I never had radiation, but I have been on Lupron, and then the Xtandi, and now Zytiga, and I'm still doing okay. I'm still here. So I know you had some issues with it. You had a lot of problems with it, but it does work. And like Ken said, any doctor that tells you, oh, you've only got 6 months to live, is not worth going through. I would not even listen to him, because everybody's shelf life is different. No doctor can predict how long you're going to live, for what it's worth.
Well, it's worth a lot, and I had 3 of them tell me that, and they all said it's variable, but I think they were being ultra conservative. And because I went, well, geez, if I got to spend 10 months to gain 6 or 10 weeks to gain 6 months, doesn't seem like that good of a deal. And if I could gain 2 years or 3 years, it would be a no-brainer.
Well, you said you're Gleason 9, I think you
Yes.
said.
Yes.
Well, I'm Gleason 8, and it's metastatic for me too. It's in my spine, it's in my hips, it's in my shoulder. I'm not going to be cured. But like I said, the Lupron and Xtandi and Zytiga have kept me around for 7 years. So didn't you say you stopped it completely, the Lupron?
I stopped everything, the Lupron, Zytiga, for almost 5 months. And like I said, my PSA went from 1 to 48.
Right.
And in that short period of time, my testosterone went from below 7 to low 600s. And so my testosterone went through the roof, although it had absolutely no effect on ED or any of that. I thought, well, testosterone's back, ED should go away. It didn't happen that way. It was still dead as a doornail. And, I could live with that part of it.
Right.
The side effects for me is that I was pretty much, an outdoors guy. And my oncologist said, don't ride a horse, don't climb anything, because if you fall, you've got a high risk of fracturing things. And my balance is not good from the ADT. It wasn't, and somebody else said before, their balance wasn't good before ADT. Mine isn't either. I think Rick said that. And mine was not great. And now all the things I used to enjoy and love are kind of off limits. And that is depressing.
Yeah, but we get.
Can't hear you, Rick. You're breaking up.
Yeah, we can't hear you, Rick.
Who wants to address?
That would be me. Yeah, I can hear you.
Thank you,
Jim.
Ken. Thank you. You give him the old pep talk, man.
I'm sorry, I couldn't hear you, Rick.
Okay. Hey, Jim, it's Ken Anderson back on. You really need to know that just because you're on Lupron, and don't get me wrong, Lupron is a drug that does, in fact, affect bone density, so you probably should ask your doctor to start Zytiga. I'm sorry.
I already am on Zytiga with prednisone.
No, Xgeva, which is a bone health
Oh,
drug.
okay.
Xgeva. Ask her about him. Yeah, ask him about starting that. And I've been doing that since day one. And all it is, and Lynn can probably expand on what actually that drug does better than I. But the fact is that just because you're on Lupron doesn't mean you can't ride a horse, or doesn't mean you can't go hike, or doesn't mean you can't go ride your mountain bike. I mean, I did notice the first 4 or 5 months that
you're the first guys that have said that, because all of the information from UC Health is don't do this, don't do that, don't put yourself in a position, don't climb a ladder unless somebody's, there. I mean, they've given me a list of things that, based on the prednisone, the Zytiga, the Lupron, and all of that, and the bone density scan, which said that I was in the early stages of osteoporosis. They said, avoid anything that'll make you fall, or where you could fall. And
you don't want a bloody fall, that's for sure. But I mean, I must admit, I when I first got back into exercising, I was on a mountain bike and I crashed and burned a zillion times before I got back kind of used to it. So the fact is that I would work your butt off trying to keep your health up and not lose muscle mass. I wouldn't give it. I mean, I wouldn't try to fall and break something. That's for damn sure. But I'd still, at the same time, not sit on your butt, because the more you sit, the worse off you'll get.
Well, the thing is, I do exercise, but I do it in the house. In other
Okay.
words, I've got,
Right, so,
equipment.
Jim,
Instead of
let me-
hiking, everything is done in the house.
Right. But Jim, I don't, look, we're not docs. We cannot give you medical advice.
No, of course not.
But what we can tell you is I have known so many guys who have done chemo, who have been on Lupron for years. They still go skiing. Their doctors tell them just be a little conservative, maybe however great a skier you are, avoid the double, the triple black diamonds. But I think it's just bad advice to tell you to shut up shop like that. And there's a lot. And the other thing that bothers me is you have osteopenia, and they haven't given you either Exgiva or Zometa. Zometa is the other drug. And I got Zometa less frequently. Jake gets Zometa every, I forget what it is now, 6 weeks, I think. But, they should be giving you Zometa, and you need to talk to your doc about, if you're so concerned about my bones, how come you're not giving me any Zometa? I mean, thank God your disease is not that far along. I mean,
I agree with you. I just didn't know that existed, to tell you the truth.
Yeah, well,
and I will absolutely ask.
Here's one. I mean, there's a lot more that we can talk to you about, but we need to move on because I need to get around some of the other guys. But
of course,
here's what we need to do. Send me. You were going to do this. You need to send me your email, and I will then connect you to Ken Anderson. So if you and I'll get you registered so we can get out our.
I'm registered on the site now.
Oh, you are registered on the site?
Yes. My internet was down for 4 days, so I finally got on there this afternoon.
Oh, okay. Okay, perfect. Okay. So I should see you on there. Do you mind telling me what your last name is so I can find you on there?
Ciccarelli, Ciccarelli, but my email is jimc522@gmail.
Okay. I'll make sure to connect you to Ken. We've got a lot of guys who aren't on this. We're going to get you back to not maybe 100% to where you were, but we're going to get you a long way back to where you were. And, if you don't have problem with second opinions, we may even guide you to some docs that some genitourinary medical oncologists that we know that are going to be a little more aggressive in terms of your lifestyle. Because we've got a few out there, including Ken's, who's very good, and certainly didn't stop him hiking that 150 miles. And if you haven't read it yet, go back on our website and read the all of you, if you haven't read it, read the 1,000 words and the 6 pictures that we posted from Ken from that incredible hike that he just completed.
Well, if we get this put together, Ken's got a standing invitation to come to Colorado, and I know the most beautiful hikes in the whole state.
He'll probably be there in a couple of knowing. Is that right, Ken? Are you making your reservations as we speak?
It is pretty hot here in Phoenix at the moment.
You don't need reservations. I got big house, plenty of room. So, yeah, I would love to be able to go back out and hike.
Let me just tell you that he took a guy, he went over to Australia to help one guy just recently. So Colorado's just a hop, skip, and a jump.
Oh, yeah. Phoenix to Denver's nothing.
Nothing. All right, guys, I'm gonna move on, and we'll keep talking with you, Jim. And
thank you.
And we're gonna straighten you out, man. Okay.
No problem.
All right. I'm gonna do a couple of things. I'm gonna do something a little bit. Sure, we got time. I've got 2 people that I want to just quickly focus on. Because both of them are board members and both of them deserve some time. One is Len, and Len will fill you in on his situation momentarily. and the other is Professor Bill, who called me yesterday and with some not very good news, that he sort of dropped out of sight for the last couple of weeks. As Jake had noticed and others, and he's been in and out of hospital so much with his UTIs and his pain management and God knows what. And he finished up going back from Buffalo, from Roswell Park down to Dana-Farber to see his docs down there. He actually was admitted to the lutetium trial, but he decided that he did not want to pursue it, at least at this point in time, because they told him that he was likely to be, in a radiation sense, pretty hot for at least 7 days afterwards, because he has so much metastasis right now. And so he's sort of shelved it for a while. And then in the course of the tests that they did last week, and he has told me to say hi to everybody, and he has told me it's fine to share this with everyone. He'd like me to do that. They found a 3-centimeter lesion in his brain. Now, it's not 100% clear to me if it's in soft tissue, if it's in the skull, or if it's in both. I suspect it's in the soft tissue, but I'm not 100% certain. And he's going to start radiation on that spot in the next few days, but it's not clear exactly what radiation. And then, of course, he has these other issues because he was super sensitive to radiation many years ago, back in 2013. I hear some slurring in his speech. I've heard that now for about 2 months. I don't know if it's associated. He is very upbeat. He thinks that the radiation is going to help a lot. He feels that he's not impaired in any way, shape, or form. I'm not so certain. Anyway, I spoke to him very briefly this morning. He couldn't really talk to me. I spoke to his brother, and I'll talk to his wife after this call. We've been crossing calls. I'm not exactly sure. I think he understands the gravity of the situation. More so after I spoke to his brother Buzz, and after Deb left me a message, and we'll keep you posted. I'd encourage all of you to write to him. He doesn't have a laptop right now because he knocked a glass of water over and his laptop's out of commission. He says he's getting another one, but send him emails anyway. Don't worry if you don't hear back from him. I really can't tell you what this means, but I can tell you that from years of knowledge that once this disease gets to the brain, it's not good. So I've been pretty knocked out from this for the last couple of days. But it is what it is, and we live with it. We've had a great year. We haven't lost anybody this year, which is absolutely amazing, and it's August. It's almost August, and it is what it is. And Bill's a fighter, and he'll do what he's got to do. And we'll keep you all posted. I'm sure we'll get him back on the call at least one more time, in the group at least one more time. Any questions from anyone? Okay. And then also yesterday I got a report from Len. and who I spoke to at some length earlier on today, and Len will give you his own report. I don't have to summarize for Len. Fratello, it's over to you.
Okay, thank you, Rick. So I think my story goes under the heading of be careful what you wish for, you may get it. As people who've been on this call for the past 6 months are fairly familiar with, I've been desperately trying to get into this NIH clinical trial for what is supposed to be currently the most sensitive diagnostic scan for prostate cancer, abbreviated PYL. It's a PSMA PET scan. And so I had just a quick background. I was fortunate enough to be on drug holiday from ADT for 28 months. And this is perhaps good news for you, Jim Ciccarelli, because I was also a Gleason 9. And now that they zapped your rib met, the rest of your condition is very similar to mine, with lymph node involvement and heavy, bulky prostate disease. And yet I was able to go on a long holiday from ADT. But in my opinion, I never would have been able to do that without radiation therapy. Okay, so that's just a little aside. So
what year? Tell the guys what year you were diagnosed originally.
Yeah, May of 2014. So it was 5 years. So more than half of that time I've been drug free. Nevertheless, in the last 7 or 8 months, my PSA, which had been stable for quite a long time, began to rise, and so I had a number of different scans, none of which showed anything. I had an Axumin scan in December of 2018, so seven months ago. I had technetium bone scan, I had CT scans, and everything was indeterminate. So I was finally able to get into the clinical trial at NIH just last week for the PYL, PSMA PET scan. And I was thinking to myself, well, this will be good. Maybe we'll pick up a couple of lymph nodes and we can zap them and I can remain on drug holiday. Unfortunately for me, the report showed more hotspots than that. And let me just put my glasses on here so I can read the report. So it started off good: head and neck, unremarkable; chest, unremarkable. No disease in the prostate or seminal vesicles. And then it gets a little ugly. It says pelvis, focal uptake in several sub-centimeter retroperitoneal lymph nodes in the bilateral iliac chains. And then under musculoskeletal, it says focal uptake is seen in sclerotic lesions of the T9 vertebral body, right posterior rib 12, and right anterior superior iliac bone. Iliac bone is your hip bone right there where my hand is now. And mild uptake in the right pubic bone, which is the lower part of the hip or the pelvic socket. Right pubic bone, comma, sacrum, and right posterior iliac bone. So that's kind of a repeat. So impression, focal uptake in several bones and retroperitoneal lymph nodes is concerning for prostate cancer metastasis. So after discussing this with the NIH oncologist or radiologist, it seemed pretty serious. Then yesterday I went to see my oncologist, Dr. O, at Mount Sinai in Manhattan. And he was more optimistic about what he said, because he basically said, okay, so what we need to know here is what's real and what isn't. And when it comes to these scans, they're often indeterminate. And what looks like it could be a focal uptake is just sclerotic bone tissue. I do have degenerative disc disease, have had it for decades, and I have some degree of osteopenia in some vertebrae and in the pelvis. So we have to try and figure out what is truly a bone lesion and what isn't. So at any rate, he has now got the images from the NIH, and he'll take a good look at it. And maybe he can come to a better decision. Meanwhile, he wants to do another technetium bone scan. I had one in January, and that revealed absolutely nothing. But he's thinking, okay, my PSA has risen in that time from 0.8 to 2.4, which is what it is now. So yeah, he wants to do like a comparative scan, technetium bone scan, to either confirm or not confirm what we saw from the NIH. And I suspect his thinking is that if there's only one or possibly two of these bone lesions, he'd like to do SBRT radiation spot thaerapi. I am going to start, after 28 months holiday, I'm going to be starting bicalutamide for a couple of weeks, and that followed by Lupron and probably Zytiga. And I'm going to hang in there with Zytiga until hopefully darolutamide is approved. And Bayer has already chosen a trade name for it, Nubeqa. So I guess they're expecting FDA approval later this year. And as some of you guys may know, the clinical trials with darolutamide showed virtually no difference in cognitive deficit and fatigue compared to placebo. So that's pretty encouraging.
Yeah, I'm sorry, because I'm a new guy, and I know I shouldn't be asking you this. Are you talking about the PSMA 167 trial?
I don't think so.
Yeah, I think the trial that Len participated in is it's 617, I think. It's PSMA 617 with the 18F DCF PYL, Pylenium. That was the scanning trial that he participated in at NIH. Is that what you're thinking of, Jim?
No, my oncologist said that he was involved in a trial of PSMA 167 that he was very encouraged with, and said it's in late stage 3, should go to the FDA soon, and he expected that it would be 4 or 5 months for the FDA to approve it, and basically it would get me off ADT and minimal side effects. And I was curious if it was the same trial, because I couldn't get into it.
Right. The problem is I don't think you have the trial right. It sounds to me like it could be.
That's what I was asking, whether it was the right trial or a different one.
I think you might be thinking of lutetium 177 PSMA.
Yes, he is.
Lutetium 177 PSMA. And if that's what you're thinking of, no, it's something quite different. We may talk a little later on today, but I suspect what you're thinking of is the lutetium 177 PSMA.
Well,
let's go back to Len. Let's go back to Len.
Absolutely. I'm sorry.
Yeah, Jim, I'm pretty sure, as Rick said, what you're thinking about is this lutetium PSMA 167, and that is a therapeutic radioactive substance. What I
Right.
have is simply diagnostic. It's not therapeutic in any way. Actually, I think I finished, Rick. Did I leave anything out? From the discussion I had earlier, I think I covered.
No, I think you hit on all the high spots. And the one thing I really wanted to raise, especially because Peter sounded this of Turner, of Dr. Turner earlier this week, is if you go back on abiraterone, whether you'll go back on the generic, whether you'll go back on Zytiga, whether you will take it with food, take it without food, and the issues around the cost, all of that. Have you given consideration to any of those?
Are you addressing Peter or me?
You.
Me.
Yeah.
Yeah, well, Dr. O said that, as we all know, Zytiga is generic. So I'm not sure it's going to be in my hands. I think the insurance company would only reimburse for the generic. What about Jake? Jake, you just started. Did they give you generic, right?
Yeah, it's kind of weird, Len. I got a prior authorization from Blue Cross Blue Shield, and they said Zytiga by trade name, but what was prescribed for me by my specialty pharmacy in coordination with Blue Cross Blue Shield was the generic. So
yeah,
I think they think there's absolutely no difference between the two.
Well, hopefully not. As to your question, Rick, would I take it with food and just take 1/4 of the dose? I haven't really decided on that yet. I'm not sure because I think there were very small studies, and it wasn't clear, how much fat was in the meal that you're supposed to be eating when you take it, and how accurately could I even measure the amount of fat that I'm taking in breakfast, for instance. So right now, I'd probably be leaning to taking the full dose.
The full dose.
Without food, but I guess I'll have to look into it a little more between now and then. I do have a question for guys who have been on bicalutamide first leading into Lupron, because I just picked up the script for bicalutamide. I noticed they gave me a month supply, so 30, take 1 tablet a day. So is that the typical dose?
50.
Just 50, okay.
Yeah, 50. 50 is the normal dose for bicalutamide, unless you're using it more as an anti-androgen, where you go to a megadose of one. Some guys use 150, but that's not as a buffer. And I remember I got 30, but I only had to take it for like 2 weeks or something.
Yeah, that's the other thing. I always thought that you took bicalutamide for just 2 or maybe 3 weeks before Lupron.
You do.
He said a month, but I'm a little leery about doing that because I don't know how quickly the breast tenderness and gynecomastia could develop. Maybe it wouldn't at all on a low dose of 50.
I don't think it would, Len. I was on it for almost a year. Not as a preliminary to Lupron, but as once the Lupron stopped working, they put me on bicalutamide, and I was on it for a year, and I didn't notice any breast enlargement. Yeah, maybe a little bit, but it certainly wasn't the first month. So I think
you were taking 150.
I don't remember. I was taking 1 pill a day. I do know that. I don't know what the dose was.
Oh, then it was probably just 50.
Yeah, it's been several years.
Yeah, and it certainly didn't bother me for the 2 or 3 weeks that I was taking it, Len.
Okay.
Anybody else use Casodex as a buffer?
Yes, I did. It was the same. 2 weeks, 50 milligrams, once in the morning, once a day in the morning.
2 weeks.
Yep, 2 weeks.
Okay, good to
I had
know.
leftovers.
Yeah.
I did have a question for Peter, I guess anybody. Peter had such good success with Dr. Rossi and the proton beam. Do they use that for bone as well, or is that only used for lymph nodes?
I think it's used for bone. I mean, I think it can be used for bone. I don't know.
This is Jerry. I had a proton beam palliative for my major tumor at Mayo.
Oh yeah, there you go.
And it was T4 to T5.
Okay.
Or
Thanks, Jerry.
right between your shoulder blades, if you want to say that.
Yeah.
So they do it for bone.
Yeah, it can be used for spot. It can be used for spot. I thought so. Yeah. I don't know. Yeah, I don't know whether, as somebody said before, I don't think that there's a lot of difference. I don't think it's going to make a huge amount of difference, Len.
Protein versus SBRT?
Yeah, especially for, I think what might be more interesting would be SBRT versus IMRT for spot. Because the SBRT is much more intense, so you might get away with less sessions, maybe a single session. And some people do use the SBRT, whether it's gamma or CyberKnife or whatever it is, they use that. Has anybody used SBRT here for spot radiation?
Rick, I had a situation in my support group. I have a guy who's been there for 15 years with bone lesion on his ribs. PSAs pretty much stayed the same for 15 years. 6 months ago, it started rising. The doctor gave him Zytiga, totally knocked out the bone lesion as far as we know. It's down to 0.2 now, his PSA from around 15 to 0.2. The doctor even told him if it comes back, PSA rises again, we'll cut the dose in half and give you some more Zytiga. So that's how it's getting treated on his. I think.
Wow. Well, maybe you'll have good success with the Zytiga again, Len, and these lesions will disappear. And let's hope that happens. I did want to say, with this abiraterone discussion earlier on, because Peter left us. I don't know. Somebody just joined us by phone. Was that Peter again?
Yes, at the doctor's office. I just came back on.
Oh, okay, great. So, Peter, Len was talking about taking a quarter dose, but a little uncertain because of the fat contents in the food. And I know that you spoke to Turner about quarter dose this week.
Yeah, he said it. He's got a number of patients that do that for financial reasons. he sees that it works pretty good. He doesn't see any big difference.
Okay. I do think the only issue there is that, and I'm not really clear about this. I know that the Yon, which is a very similar drug to abiraterone, has a smaller molecule size, and so it really doesn't lend itself to the quarter dose. I'm not sure about this genetic abiraterone. I think that the generic abiraterone. I think the generic abiraterone is the same formulation as Zytiga.
Yes.
Do you know, Len? It is, isn't it?
Right.
Okay. So really, there are three choices right now. There's Yonza, there's the genetic abiraterone, and then there's Zytiga.
Yeah, actually, I wouldn't mind trying the Yansa if the insurance covered it.
Mm.
Yeah, because
Then
you
I
can
have the option of eating or not eating. Doesn't matter.
exactly.
Yeah.
You know, somebody last week, I don't know who it was, but somebody last week mentioned 300 calories with the reduced dose of Zytiga. I have no idea who that was or where they got that from, but somebody mentioned 300 calories.
Yeah, you're right. Yeah.
You don't want to eat too much, but you don't want to eat too little if you're going to play the quarter dose game.
Jake, did you get any traction, Jake, with Janssen about looking at the roadmap, the prostate cancer roadmap site and stuff
Yeah, I went
for
there.
reduction?
What was I supposed to look there? I did look there.
To see if you could get a discount, see if you can get some help for the drugs.
Oh, well, I had the generic, Peter, so they're not interested in me.
Okay.
And where are you, Jake, in terms of cost? Do you know yet?
Yeah, I had to pay $50 a month.
Okay. 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 Well, that's manageable.
Yeah, it is. I don't have a problem with that at all.
Yeah.
So
Okay.
I'm not going to worry about reducing the dose or anything.
Okay.
Unless I can find out for sure there's, how to do it.
Right. Okay. Well, we don't have a lot of time left for the general public today, and I do apologize to you. I can stay on a little longer if there's anything, but I'm going to do a quick round robin. But I just have one very quick question for Les Shelderup. Les, did you ever get a biopsy done at Mayo?
How was that again?
Did you ever have a biopsy done? Have you had biopsies done at Mayo Clinic?
Yes, on some lymph nodes and so forth, and spine, when I had cancer on the spine. But there's been no, well, come to think about it, I think they did something on the prostate too at one time too.
Okay, because we have a new gentleman, you weren't on early on in the call, but we have a new gentleman who's on from the Milwaukee area, Bruce Shrimp. And Bruce, I was wondering on his behalf how easy it is to get copies of your biopsy report from Mayo. Were you able to get copies of your biopsy report from Mayo?
Actually, while you were all talking and I was listening to you, I went on to the Mayo Clinic portal and I found my biopsy report.
Oh, okay. Well,
I read it.
Okay, well, next week, we don't have time this week, but next week you'll give us a report on your biopsy report. Then you can tell us exactly what went on.
Ready?
I will do that.
Okay, that answers that question. And Larry, Bruce, meet Les, and I'm just trying to figure out where you're in Milwaukee, and Les, where are you? Remind me again where you are.
Near Moline, Illinois.
Moline, Illinois. That's right. So, and both of you have gotten some treatment at Mayo. All right. Look, what I'd like to do now, and let's figure we're going to go till about quarter after, so you can plan. But I'd like to run down and see who has something that is burning for this week. If not, I'm going to ask you to hold it to next week. And let's just see. So, Carl, is there something you'd like to talk about this week?
Yes.
Okay. Joel, is there something for you this week?
The reason I came on this call tonight was I wanted to hear Len, and he has already briefed us. So I just have one more question for Len.
Yes, please ask it now if it's a question for Len. I'm sorry, I forgot to open it up, and let me open it up right now for any questions for Len.
Okay, Len, as you know, I had already tried to apply for the same trial you went to, and I wasn't successful because they did raise the bottom limit. And question is, the doctor you talked to after you left the scan, the PSMA PET scan, was there any discussion at all of getting you the lutetium-177, maybe in Germany or Australia, so you could find out for sure? Because the PSMA is only expressed on prostate cancer cells. So if there's some doubt as to whether some spots are cancer and some spots are not, the PSMA lutetium PET scan would only address those PSMA spots.
I'm only aware of lutetium being used as a therapeutic, Joel, not as a diagnostic.
Correct. So, but you already had the diagnostic. Isn't it possible that it's time for you to get the therapeutic now?
Oh, I don't think so. First of all, I wouldn't qualify because you have to have just about exhausted every possibility of approved therapies like chemotherapy and at least one, if not two rounds of the second generation ADT drugs, like Zytiga or enzalutamide. So I definitely wouldn't qualify.
Okay, well, I didn't know that you're teaching me something. Appreciate it. I was not aware of that. So, and of course, that clinical trial at NIH is not for the therapeutic, just the diagnostic stuff.
Correct.
Right. So,
Right.
That was it.
Joe, there are a number of trials across the country for the therapeutic lutetium-177 PSMA, which I think is what Jim was talking about earlier. However, as Len correctly pointed out, most of them require that you have done chemotherapy and at least one second-line anti-androgen. Now, I don't know about Germany, but I do know that if somebody wanted to spend the money, you can get lutetium PSMA in Australia. And we actually know somebody who's doing that right now. But he has had a very, very unconventional ride. He got diagnosed back in 2001 and essentially took no action until his PSA was 134. And that was like a year ago, and he started doing ADT. When I say no action, he had original treatment, but even the original treatment was fairly, I think, mellow at the time. But he doesn't want to do chemo. He doesn't want to do second-line anti-androgen, and he's paying out of pocket to do the lutetium-177 in Australia, and I can connect you to him if you would like. But in this country, as far as the trials are concerned, Len is spot on.
Very good. Thank you very much.
Rick, this is Jim. Yes. For one more short interruption. I was given information that said the PSMA therapeutic trials are almost to an end, and they're going to go to the FDA soon, and they expect the FDA to fast track them. Mm-hmm. And that's part of my reasoning in being skeptical of getting into radiation at my stage. And I know I have to do more tests and qualify, and it's months down the road. But at least from my information, fairly good was they will get it to the FDA in the next 60 days, and then it's up to the FDA whether they fast track it for therapeutic purposes or not. And right. Whoever said it's only being used or tested on the very worst is absolutely right. That's right. Exactly what they told me.
Right. So again, I think you're right. I mean, there's been enough trials. I do know people that, I mean, Professor Bill was just admitted to a trial last week. So, you know, they are still admitting, but you do have to have done all these prior therapies.
Yeah.
My guess is when it gets FDA approval, it may well be only at the end of after chemotherapy and after a second-line antiandrogen. So it may not even be available for you. I mean, you are pretty early on, as Len said, he is too. You would be fairly early on for lutetium. I mean, it may turn out 5 years from now that they use lutetium much earlier in the disease process.
Right.
But you know, you're still castrate sensitive to the LHRH drug, and I think as a minimum you would be have to be castrate resistant for the lutetium in the FDA approval. But let me keep moving here. Any other questions specifically to Len? Okay. Let me keep going down. So Carl would like some time. Paul Frieda, anything for you?
Nothing tonight, thanks.
Thank you. Dennis, anything for you?
Nothing tonight.
Thank you, thank you. Jerry Pelfrey, anything for you tonight?
Oh, we'll talk next time.
Okay, thank you, Jerry. Appreciate it.
Yep.
Ken Anderson, anything for you tonight?
Nope, I'm good.
Okay. Larry Fish, anything for you?
No, thank you, Rick. Trying to wake me up.
And I want to publicly acknowledge Larry helped us with, gave me some guidance on a grant application I made this week, and I'm really appreciative, Larry. Thank you so much. I'll keep you informed. And we will get better.
Minimal.
What's that?
It was truly minimal.
It helped, and they will see a difference, and I think that's important. And we will get better with our grant writing under my mentor, Mr. Fish.
Thank you very much.
Peter Kafka, are you still with us? I know you're in the doctor's office. Is Peter with us? No, I think we lost Peter. Les, anything for you tonight?
Not tonight, thanks, Rick.
Okay, well, everybody's been pretty patient. We'll go to Carl, and Carl. Oh, who did I miss? Jake. Oh, bloody hell. I missed you again, Jake.
Last week we admitted that I should always go first because that was the appropriate thing. And this week,
right. Oh, mea culpa, mea culpa, mea culpa. Okay.
This is Bruce. You missed me too.
No, I didn't miss you, Bruce. You had the first 25, 30 minutes.
Sorry about that.
Yeah, I didn't, and so did Jim. I don't go back to you. You had your time today. Jake, is there anything you would like to speak about tonight?
Yeah, I just wanted to point out real quickly that you keep mentioning next week, come back next week and we'll discuss your results or whatever. Next week is a special curing cancer.
Oh, you're right. You're right. Okay, quick promo and then Carl. Next week is a 5th Monday and a 5th Tuesday. So we don't have a group next week. So the next group we will have will be the first Monday of August, the 5th of August. That will be our next actual group. What we do have next week, and I hope all of you will attend, is a webinar. And the webinar is on the language of cancer, and we have some fairly good panelists, some very good panelists. And it should be an interesting session. It'll start at 8 o'clock Eastern, 5 o'clock Pacific, next Monday night. I will be posting some slides to the website, and we'll have a presentation for about 15 to 20 minutes from Professor Richard Wassersuk, and then we'll have a fairly good panel, and then there'll be plenty of time for questions. And if you've got any questions, email them to me ahead of time or use the chat window. If you're on the telephone, you're going to join by telephone, which you can do. You'll be able to download the presentation, and you'll need to email to me or maybe to Len. I'm not sure how we'll do this yet. We may ask Len to handle the questions because he did such a great job in our last webinar. But I do encourage you, and it'll be really interesting. I mean, the thrust is that some people get really offended around the term survivor or around some of the military terms like warrior and fighter, and yet there are other people who are really stimulated and driven on by those, and that's really what we're going to be talking about. And it's pan-cancer, so we'll have people from different cancers all coming together. So thank you, Jake, for reminding me that we don't have a regular meeting next week. Carl, you're up.
Okay, I think I'll talk earlier today, I was at the local radiology office, and I had several x-rays. As a result of late last week, I followed up with my doctor's office, my oncologist's office, and said, although I was recently diagnosed with having a partial blood clot in my left leg, I was put on Eliquis. The partial blood clot has, I don't think it's entirely gone away, but it really has, there has been some relief there, a good amount of relief. So I had an updated Doppler last week because I kept complaining about the fact that I still had pain in my left leg. And the Doppler showed there was good blood flow. And where they left it with me was that, well, they'll have the doctor get back to me to say, okay, well, maybe we need to have an x-ray. So that's why I have the x-ray today. So ultimately, the question I have, so I have some aches and pains. Maybe it's arthritis, maybe it's something else. Not quite sure what the x-ray will show. The technician did say, well, if it's arthritis, they'll be able to tell that it's arthritis because it's in the bone. They won't see anything that's muscle related at all. So I guess it's somewhat limited in what they can be able to tell me what I have. But I had been originally diagnosed with pelvic bone metastasis, and quite honestly, more and more I've been feeling some discomfort in sitting for any length of time. And even now standing, I have some pain in my left leg, so I figured I better get jumping on this and see what the heck's going on. But in the meantime, my PSA is less than 0.01 as a result of being on the PARP inhibitor, olaparib, for the past 3 or 4 months. So while my PSA is down, and I guess I don't know whether it's a false sense of positivity, so to speak, that, well, the PSA is not the only criteria for determining the disease or the progression of the disease, and that's ultimately my question.
That's such a good question, and it came up for me earlier this week when of all people, Ellie Van Allen referred a guy to us, which was a real compliment. And I also want to say, just as an aside, that Ellie's been helping me navigate Bill at Dana-Farber as well, as a little push from the back. So he's just been fantastic. He's such a great guy. And Ellie sent a guy over to me who doesn't make PSA. Gleason 10, he had an RP 2 years ago. His disease has come back. But when he had the RP, this Gleason 10 guy had a PSA of 1.0. So this is a guy who doesn't make PSA. And of course, his concern is, how the hell am I going to monitor my disease when I don't make PSA? We're doing PSA checks. My docs tell me, don't worry, because your PSA is low. I know my PSA is low because I don't make PSA. And we talked for probably 45 minutes. And I think that there are other tests. Certainly the alkaline phosphatase, which was the old, aren't I right, Len? Wasn't that what they used before PSA?
Well, alk-phos would be elevated if you had bone metastases.
Right, but there was that was what was frequently used before they discovered PSA, I think, as being.
Oh, I think you're thinking of acid phosphatase.
Oh yes, maybe I am. Yeah, PAP. What's that one?
Yeah, prostatic acid phosphatase.
Okay, prostatic acid phosphatase, which is a guide. ALK-phos, which is another guide, which really reflects bone activity, but it can be deceptive because it can be high when bone is when the cancer cells are dying in the bone. That can show as high, but it can also be high when you're making a lot of extra soft bone from the cancer spreading. So you have to be careful with the ALK-phos. And then, of course, the scans, which are probably the standby, getting the same type of scan on a pretty regular basis to see whether your lesions are shrinking or increasing. Would you like to add anything to that, Len, or I mean, how to monitor in the absence of PSA?
Well, I think you captured it, Rick. I was just thinking of Eugene Kwan up at the Mayo Clinic, who in his talk at PCRI said, scanning isn't, something like scanning isn't everything, it's the only thing. So just to give you an idea, Carl, I mean, he thinks that scanning is absolutely essential to really understand what's going on because of cases where, for whatever reason, you're no longer producing PSA.
My ALP is very low also at this point.
Right. When's the last time you had a scan?
Probably about 2 months ago.
Just 2 months.
And I'll have the results of today's scans. Actually, believe it or not, I have an appointment with my primary care doctor on Sunday. They're open 7 days a week, and sometimes it's on the weekends. But my meeting with my oncologist, Dr. Soraya, I do have scheduled on July 30th as well. So we'll talk about that stuff.
I mean, I don't think there's much. There's a lot of sense in scanning more often than once every 6 months, unless there's something very specific that you're looking for. But there are some folks that never do scans, or very rarely. I mean, the scan that Jake just did was the first one he's done in 6 or 7 years. So, but if it were me with metastatic, I would probably want to get scanned at least once, if not twice a year. I don't think there's anything wrong with that. I don't think the amount of radiation is going to be that invasive.
Yeah, I did have my Aximum PET scan back in March as well.
Right. And the only issue there, and we ran across this with somebody, maybe Len can remind me, is the degree of comparability between the Axumin scan and a conventional MRI scan, because the doctors like to, if they Oh, it was with Jake. You know, they didn't want to compare the scans because they're not comparable. So I just give you a heads up because you can't keep going on getting Axumin every time. It's going to cost you an arm and a leg. Because I think you get one, or I think you only get one. You might get more than one. I don't know.
I think it's once per year. Medicare would cover.
Is it once per year? Okay. Thanks.
Rick, I didn't have it wasn't an MRI they didn't want to compare. It was another PET CT they didn't want to compare because I had the FDG, the old glucose-based one that everybody agrees is no good for prostate cancer. They didn't even bother. That's the one I had that they didn't want to compare to the Axumin.
Yeah.
For what it's worth.
Okay.
But Rick, I agree with you that, 2 scans a year would be sufficient normally. But in Carl's case, if you're becoming more and more symptomatic and there's nothing to explain it and your PSA is not moving, I might recommend more often, scanning more often.
Yeah.
Yes, and that is what the oncologist has said.
Yeah, no, I mean, like I say, I think I would say normally once or twice a year, unless you're looking for something special, I think is what I said. And in Carl's case, we are looking for something. So there is good reason to do it more often.
And hopefully it will be useful. The x-rays will be useful. I don't know.
Yeah. But you're saying that your ALK phos is within normal levels?
It's below normal.
It's below normal. Okay. And are they measuring PAP?
Not that I'm aware of, no.
Len, can you remind us what that PAP is, that phosphatase?
Well, it's just another
phosphatase?
prostatic acid phosphatase. It's just another antigen that they find is overexpressed on prostate cancer cells, and but I mean it's not as sensitive as PSA.
Right.
That's why it was replaced by PSA. It's actually the antigen that they use in Provenge when they try to train your lymphocytes to attack the cancer cells. They expose it to the PAP antigen, so that the lymphocytes recognize that and inject it back in your body and attacks your cancer cells, which I always thought was a peculiar stimulant or antigenic stimulant. I'm surprised they didn't use something like PSMA or maybe PSMA wasn't as prominent, 10 years ago as it is now.
Yeah. No, I agree.
But yeah, you could ask them, Carl, if do they monitor PAP, prostatic acid phosphatase.
Okay. Yeah. Within the next 2 days, I'm having updated lab work in advance of my appointment for next week, so I'll be looking for that.
Yeah, and you've never made a lot of PSA. I'm just looking back. Have you, Carl?
Well, the highest it was at was 20 right before I had my biopsy, and then dropped from there. And it went from 5 point something to 20 within a matter of 6 weeks, and that's where everything got.
Yeah, but it never got much higher than 20. So you certainly don't produce nothing, but you don't produce huge amounts. So, anybody else have any suggestions for Carl? Okay. Well, we're giving you a couple of ideas, but I think we're all agreed that scanning is the order of the day.
Right. Okay.
And please tell us what you learned from the scans from today.
Okay.
we are anxious to find out. I have put, for those of you online, and if you haven't seen the blog post that Ken made, I've put it in the chat window, so you can click on that and see some fabulous pictures of the Washington skyline, high line, whatever you want to call it. It's an inspiration, as is the guy that did the hike.
Yeah, I agree. I wanted to congratulate Ken and thank him for that inspiration. Now that I'm about to go back on ADT, I'm glad you posted that. It was amazing.
Yeah, thank you, Ken. Thank you for taking the. Thank you. Thanks for taking the time to write it up. And you know, we encourage all of you to write up. If there's anything you want to put on the blog, write it up. Send it to me. I'll work with you, and we'll get it on the blog. And you know, the more interesting and especially the inspirational and the fun stuff we get on that blog, the better it is. Some of you may have heard right at the beginning, I just posted something on there about hearing loss, because it's a subject that rarely gets talked about in the context of cancer treatment, but it deserves more attention than it gets. There's good stuff that goes on there. Thank you also to those of you who had something today and held it back, and save it for August 6th, or if it's something that needs more urgent attention, don't hesitate to reach out to me or to Len personally, and we'll help you before that point in time. And with that, I think we're done for the night. So I'll say good night, everybody.
Good night.
Good night.
Good night.
Later.
Guys.
Good night.